Hey guys, I'll be right back. Just prepping, trying to get everything ready. Been a fun day so far already. Alright, just trying to get the kids settled and everything beforehand. We got in a ton of information this weekend, guys, from everybody taking their exam. One thing I loved to hear was that one person took their exam in September and they walked out of their exam just crying in their car afterwards. And then they took it again this weekend after working with me and walked out of there early before the exam time was over with, smiling from ear to ear, feeling so unstressed and relieved and happy that she took the exam. She felt really good about it. So I hope that she did pass, but just having a better testing experience means all the world, especially if you've taken this exam before, because it is nothing to do with coding, and everything else about is put in place for you not to pass, for sure. So that was super good to hear. This page happens to be from one of my ICD10 books. I went through and had written in which way the direction that the lungs, the blood was coming in from the lungs and the heart and stuff. I wrote it here, but I didn't write it in my CPT book. And then that happened to be in one of the questions in my exam, and I forgot that I had done all this. But it was that question, was the superior vena cava. They wanted to know it came in from the right lung, from this way, and I forgot where my information was. So the hard part about this exam is keeping everything organized that I need you to write in the books so that you have it in your books for the exam. The other part is knowing where you put the information. So that information would be better served in the CPT book and then writing it in on the lines here. This is another version of my CPT books where this is the same year, 2020, for both books, where I wrote it in one place but then didn't move it to this place and then forgot it was in this place. So that's how my books used to look. Now, of course, for you guys, I did it differently, and when I updated my books and everything and made sure that information was where it was supposed to be, it all needs to be in a place where you can definitely find it for sure. Don't forget that we want to keep any laws, regulatory definitions of things that are part of your program in the front covers before your E&M section, this red section. So this is where I would put definitions like OPPS, NCCI, HIPAAs, what does Part A, what does Part B pay for. You have all this white space in the front of your book. Any of your guide, like information as far as when the CPT codes are updated, and then when they're published is already up here too. This is part of the information that you may need for your exam too. I've seen that question multiple times. So keeping all that up here in the front and writing a whole lot more than what I've written would be very beneficial. I did that in my older books too, but what I did was I ended up writing it all in one color, and then it just sort of blended in together with everything else. So it wasn't as beneficial because it looked like all one blue blob. So be sure and separate things out with colors, if I can find it where I wrote it, because that's super helpful. Just having it all in one color is sort of unhelpful because it doesn't separate anything at all. So yeah, I'd recommend doing what I started doing here, is writing everything in different colors. So it's helpful for sure for definitions. Most definitely. Don't forget you do have some abbreviations, prefixes, and suffixes in the beginning of your book. But the main thing is your list in the very, very back cover, back here. Don't forget about your abbreviations. They're in alphabetical order, so you don't have to worry about certain things being in a particular section to find it. They're all in alphabetical. We had this new one come up with our exam this weekend. Somebody took it and their abbreviation was JVD, which is not back here. So I just went where the I's and the L's are, and I just wrote it in. JVD means jugular vein distension. I wrote abbreviated words so that it's there, and it's where the J would be if there is a J. So if you have any added definitions, you can write them in, and then that way it's all kept back here. Not definitions, but abbreviations. Those acronym thingies. Super helpful. One more thing I wanted to point out back here in the back of the book is Appendix C, guys. I know a lot of people aren't scoring very well in their E&Ms, and I keep going over it and going over it. But there is a lot of examples back here in the back of your book for all E&Ms. They go in depth with what an inpatient hospitalist would look like. All these are separate examples. And you can take these examples and go move it to that 221 code. You can write it in what they do. I like to pick the ones that don't say initial hospital. Like if they're just giving me an example that says the same thing, that's kind of unhelpful because usually the test question will say something different than that. Like our example today that had PCP, admitted patient for IV fluids. But everybody kept thinking it was an ER visit, but it wasn't. So when they have one right here that says something about hospital, admission, or anything that starts out something different than initial, but all these on these 2 pages are all for that one code. Just like what we had in our example in our chat room. And if you're not part of our chat group, we do work in that every day, all day long. And it's on Messenger, and you need to come find me at Jen Brewer on Messenger. Ask to join our group, and then you can work with us too daily on examples. But these are a great resource for all these strange codes that are consultation, hospital admissions. They go through and give you a ton of examples on what scenarios would work with that particular code. And you can pick these out and move these to the code just right back in the front of your book and write them near the codes so that you can use them as a reference during your CPC exam of exactly how a subsequent care would be in a hospital, what kind of consultation visit they have all those clinical examples that you can write down here at the bottom of the page of a little bit of a scenario of how it was going. That way you'll have a reference and you don't have to go all the way back here and look in section Appendix C. So check those out. See if you see anything that's super helpful back there, and move the examples here to any white spaces near the codes that they have listed. We are in, hey Destiny, in the 2021 CPT book. We are at Appendix C in the very, very back of the book. I was just pointing out that the CPT book does have a whole chapter full of clinical examples of how to code a lot of these fancy E&M codes that are hospital inpatient. Each one of these little paragraphs is another visit under that one particular code and how it would look if you saw it in a question scenario. Here's 99222. These are on page 894. And it goes through and does all the inpatient, all the subsequent hospital care visits. It does all the consultation scenarios. It does inpatient consultations. It does emergency room visits, critical care, and prolonged services. A few little bitty other things like oversight services and neonatal. But it's super helpful for sure. Be sure and check that out and read some of these scenarios and move them to the codes in the front of your book so that you'll have them for quick reference during your exam is my suggestion. For sure. I don't nearly have enough examples written in my notes even for initial hospital visit at all. So those would be a great resource for that. I have a couple, but not nearly enough at all. I want to make sure that everybody realizes that critical care is super, super easy to code during the CPC exam. All you have to do is read the test question, find out however many minutes they were in critical care, and use this chart above right here to figure out what code it is. If it's 2 hours and 40 minutes, then you're going to code 99291 with 99292 times 4. This is super handy dandy. We love critical care. Easy to do. We don't need to know if they're new patient, established. None of that matters. The only thing that matters is time. Don't follow the guidelines or anything that's written underneath the code description, like 30 minutes to 74 minutes is this code, and then each additional 30 minutes is this code. Don't do the math and all that. Ignore all that. Just use this chart right here. Super easy. Look up the minutes or the hours, and then it tells you exactly how to code it. Super easy. Can take you less than 30 seconds to do those critical care questions. We love critical care. Love to see those pop up on a test. They're super easy. There's no confusion at all on those. Love it. Can you do this if you're visually impaired, or is it all fast-paced, no time to slow down? For the CPC exam, if that's what you're talking about through Aapc, you can get an ADA, which will give you more time for visually impaired, which will give you a whole hour more than everybody else. And my husband is visually impaired, and he runs an entire store, our Hobby Lobby. He opened it. He really has to get down, even with his glasses, and like put the piece of paper right up next to his glasses to read a lot of things that are fine print, and he does fine. Everybody seems to adapt. I know the good thing about all this is you won't be actually using books when you are coding and working in a practice. Everything will be on the computer, and you can adjust fonts and sizes and things, and you can even have the computer read to you. So all your coding books and everything are all electronic. You'll do code searches through a computer program that'll bring up the proper codes by your key terms that you type in. So if you could just get through the exam, you can do this for sure. Hey, Connor. Hey, Jenna. Ooh, I had some people that were coming up due for their exams pretty soon. I don't know if I've seen some of them lately. We had Allergic coming up. We had Spencer and just coming up too. I wonder if Libra passed. She had one at the end of October. I was wondering about that one. We had like a Pfeiffer on December 4th coming up. A JM coming up on the 23rd. Heather. So I was just wondering how everybody was doing. Tiffany had hers on the 14th. Jackie's coming up in December. We had a Steph. And Sade. Sade is coming up on the 20th. Sonia. I wonder how she did. She was supposed to have hers on the 6th. But we've got a lot of people coming up here on the end. There's Ange. Kimberly. Tiffany. That was me. I got some info for you, just getting it all together for Exam B. Oh my gosh, you rock, Tiffany. Thank you so much. Midnight, can you do that? Okay, she asked that. Most coding, as far as a job goes, too, can be where you need to do like 100 cases a day or 90 cases a day or something like that, but that's like, so if you have 8 hours, 90 cases, that's 10 an hour, somewhere around in there. But you get faster as time goes by because you learn where your EHR is, where data is, where your med list is, where your history list is, which tab holds your PDFs, so if you need to look at any hospital notes or something like that. So it's always slow-paced at first, and then you get better and faster as time goes on, just like anything. Auditing might be a good place for you to go to. If you get your CPC, then you can go and get your auditing certification too, and that's a slower paced job with more pay for sure, because they give you more time. If you're an auditor, you get to spend all the time you need to audit charts and then make your report. So I prefer auditing to coding for sure. Thank you. It was a fear of mine of not being able to do this as a career. Absolutely. Yeah, no reason at all. My poor husband can't hear or see. He runs an entire store and staff. Bless his heart. But I guess it's good if you can't see or hear him talking about you. Let me check on the kids real quick. I'll be right back. On that floor. Their room literally looks like a tornado hit it. I mean, stuff is scattered like somebody just threw it all up in the air and poof, there it goes, down on the ground where it goes. Oh, it's only Monday. Okay, where'd I put the mouse? For the keyboard? Oh. There it is. All right. some more things. I want to make sure that everybody is getting their book prepped for this CPC exam. Certain things you should do is fix your out-of-sequence codes by writing the page number down. Besides all the red codes throughout the entire book, put the page number down where their codes are at, because there's nothing worse than getting to the exam. This code is on your exam, which is on page 59, but the actual code has been moved to page 53, and then you got to go search for it. They give you a range of codes to go look through to see where it's at if you do the prep ahead of time and put the page numbers down. This will save you, especially in lab and path, where every code is out of sequence. It's a nightmare. It's truly a nightmare. I completed my exam not ever finding one code. I couldn't find anything. And I paid for a lot of information from people who supposedly had passed their exam and knew how it was, and they never said anything about anything being out of sequence and needing to put page numbers down. Some simple little thing like that is very valuable. Write the page numbers down. You don't want to get caught up in this range mess, because even with the page numbers down, it still can be difficult to find them because you push the codes that are normally in correct order out of order, because these are now where these normal codes should be. It just creates a huge nightmare. You really need to know where your codes are at. So please do that. Then you need to mark a little bit of something that's the difference between every code. Like these are neonatal, these are just peds. That's a big difference. You know, you need neonatal is less than 28 days old, and then these are over till 2 years old. Sometimes your questions will say subtle hints about it being an older child, but they won't say it's peds, or they won't say it's neonatal, but then they'll tell you that they're 3 days old. You need to figure out which code is going to go in for initial inpatient pediatrics. They're the same codes. The only difference is the age. So knowing the differences between the codes when they're giving you 4 to choose from is super helpful. When they are out of sequence and I do find them, I put a red line underneath them, just so that if I am here on this page looking for my out of code sequence that I just went to try to find and I can't find it, and then I referred myself back to this page to find it, it's highlighted. The barcode hashtag sign is supposed to allow or alert us that that's an out-of-code sequence or an out-of-sequence one. But I like to make it red because when you first see it, it's red. So they should carry that over as far as an auditor is concerned. It should continue to be red. That way it's the same sequence there for sure. But that is helpful. Don't forget about the front cover of your CPT book. Also has a list of all your modifiers in a quick little short, not really all of them, but a few, most main ones, and you can refer to this. It's super easy. It's a lot easier than looking at Appendix A. At the back of my E&M section, I did do my own little abbreviation cheat sheet right here too, that I like to look at because it's super easy to find, because it's quick at the end of the red section, and then it's just the modifiers that I would mostly use for E&M and for integumentary anyway. So they're right there. I like them there, but you can use the space for whatever notes you want to use it for sure. For anesthesia, the guideline pages do not tell you that you're going to need a lot of modifiers, and you need a lot of modifiers. So before you take your exam, be sure and write down the 4 different types of anesthesia and the differences, the definitions, because knowing the difference between regional and local and a MAC is super important for the exam. Plus, you need to write down all the anesthesia modifiers like QS and Q8, Q9 are all for MAC. You need to know those differences and have them handy. They're all in the HitPicks book. which is insane, and not here in the guidelines. So be sure and get that information written before your anesthesia section. That way you have it. One more tip for anesthesia is this 99100 code. It's used if your patient is under 1 year of age or over 70 for anesthesia patients if it isn't listed in the CPT code descriptor. So that means, like this one on 00326, this one has an age listed in it, so you would not use that code. But the one right above it is anesthesia for an esophagus if a patient had a thyroid issue that they were doing of the neck and she's 70 years old, you would add that code. If you had anesthesia, I don't know for this rib resection for a newborn baby that was less than a year old, you would do that if they had a floater rib. Some people are born with an extra spare rib. You could use this, but you would have to use that 99100 code if they're less than 1 year or older than 70. But you do not use it when the code description actually has an age in it. So just keep that in mind. And I went through and wrote no 99100 there so that I would be remembered during the exam. All the pink codes were codes that were on my CPC exam. They used a lot, 10 questions out of the section. Out of these, just 5 pages is a lot. And they will use them during the exam for sure. So writing some examples is super helpful. Knowing AKA terms is super helpful because sometimes they're going to say words that are not in the description. And the way I attack the exam is by not reading the questions at all and doing word searches based off what's in the descriptor for each CPT code to find your answer in the question. And that's unhelpful when they don't use the correct terms or the same terms. So as I find AKA terms, I let y'all know. Like a pump oxygenator was recently called a heart-lung bypass, which is cool. But it was also called a cell saver. I could see that because they're taking your deoxygenated cell out of your body, putting oxygen in it, and then putting it back in your body. But that's really getting pretty shady as far as calling a pump oxygenator or a heart and lung bypass the same thing as a cell saver. But that's what the question said. It said they were doing a coronary bypass with a cell saver. Really? So anytime they do that, I'll let you know. Yes, James, Michael, what would the class like to know from you? What do you need your mommy for? What?
I was going to close the door so the guitar wasn't as loud.
Oh, that's fine. What's Travis doing? Is he still? Okay. He's on the computer. What are you doing on the computer, dude?
Checking out to see if I want.
You are not allowed to be on Google, and your fingernails are covered up. Fix that.
Almost done.
No, they're not almost done. Get out the stuff and get it off your nails. Say goodbye, James.
Goodbye.
Sorry, my kids. Oh, my gosh. He's like, it cannot wait. I have to know if I can shut the door so I can play my guitar. Oh. Okay. Cell saver. I'm still not over that one. That one will get me forever. Come on, focus. Focus. And now I can't get this thing to cooperate. And the phone is going off. Hold on. I gotta fix this thing. 1 second. There you go. Pop back in there correctly, mister. There you go. There we go. I got another one of these thingies, but this one is just not tall enough. Like, that cord just goes super short, and then this one is too tall. It's like, okay, people. Thanks, Jess. We put everything in the Creator Fund back into the program, so if anybody wants a copy of my notes that are on Etsy and they can't afford it, we will send anything that was sent through the Creator Fund back to them and let them get them for free. If you want to schedule tutoring with me, that's at Medical Coding by Jen. You can go there to schedule a time with me if you want me in my books. Then all these lives, if TikTok records them, they are reposted on YouTube at Coding by Jen, so you can see all my old ones that we have recorded. Y'all know where TikTok is that I put videos on. And then Messenger is our chat group. You have to find me at Jen Brewer, and then I can add you to our chat group. And then if you want copies of my books page by page, that's available on Etsy. There is a link in my bio. I don't think you can click on it during the live, but after the live you can click on my face, that fuzzy hair, and then it'll take you to a link in the TikTok bio.
I have to know that.
I think that's here, and there's 20% off right there. If you click that, it'll take you there. And put that in the shopping cart just in case you need it. But I am more than happy to show you how to do this all by yourself. You just box the child and parent code, which is explained in the front of your CPT book. So on page, whatever this is, VI5, it explains what a parent and child book is, or codes are, because this is the instructions for using this code book. It shows you what the parent and child code is. It tells you what to highlight, which is after that tiny little semicolon, and then you highlight what's afterwards. You do this for all your codes that have child and parent codes. Then you go through, and the ones that do not have parent and child, you mark the differences. This one's permanent, and this is just an access. This is a transvenous replacement. So replacement, access, permanent would actually be the code words. I got better at marking the differences the more I did this for you guys throughout this book. The best section, of course, is in the back. When I got really good at all this is in the medicine section. It has everything that you might need if you wanted to copy or get one section and then copy it over to the other sections. Medicine is pretty cool. It's got all the little tips and tricks that we found out along the way. And let's see, what else did I want to go through before we got to our exam stuff? Oh my gosh. I can't believe how great it was to hear somebody say how helpful collecting what was on everybody's exams and then sharing it was for everybody that recently took it, because it sort of just went down the road with every little thing that we had captured. It went along the same route, which was super helpful for everybody. I've got some updates on this, and I'm going to have to go through this and add more details to it, because some things I just got just like a code, a CPT code. But if you know in advance what's on the exam, basically word for word and section by section, it's super helpful and you're not surprised by some information. So I've been collecting it by exam and writing down what we have, and I have a ton of information from this weekend that I haven't gotten to yet. But so far we know we have the sesamoid gland. So this is in your foot. And so what you need to do is please stay organized. Don't start writing all this stuff everywhere willy-nilly. Go to your foot in your CPT book and write down sesamoid bone right there, so you'll know where it's at. Okay. The other thing that was on their exam from this weekend was the acronym NCCI for the National Correct Coding Initiative. Be sure you know the correct wording for those. A lot of things I like to just go to the beginning of it, like I did with HIPHICS, and just write exactly what does those acronyms mean, because sometimes they'll ask some of the simplest things, but then they'll mix up some of the middle words. And if you don't actually just have it written out plainly in front of you, sometimes you can get confused, especially during an exam. I'm an awful exam taker. I have one kid who has fetal alcohol syndrome, and he is like a savant, can go through a test and have no idea what's going on and pick the right answer every single time. Just crazy. But then I've got one kid who will study his butt off for hours and then blank on the exam and not be able to answer anything. And that's the same thing with me. I like to verify and see it in person before I answer it, because I get unsure of myself. Even as an auditor, even 20 years in the medicine field, I still, during a high pressure exam, it's ridiculous how stress can get to you. So be sure you know when things update too. Like HitPix updates quarterly, where CPT updates differently too, even by section. And all that is listed in the front of your CPT book too. So don't forget that that page is available for you. And it tells you when the CPTs are going to update and when they go into effect. And that's up here in the front, because that could very well be on your exam too, if I can find it. I know it's up here somewhere. There we go. So front of your book, it tells you when their release date is, and then when they actually go into effect based on code selections. So be sure you know where that is, just so you can find it. Other scenarios I need to find some examples for is possible pneumonia. How do you code it if it's a possible or fixing to be? We had one this weekend that was a very good one. What does it mean when they're fixing to have a heart attack, but they haven't had a heart attack yet? So impending or threatening, where would that be? Where would you find that if you needed to find that right away? Let's see if I can find it. There's 3 diagnosis codes that you can do and use during your that are impending, and myocardial infarction was the one that was on their CPC exam this weekend, which is really, if you look up I-20, I think it's ischemic something heart disease. But those are the 3 diagnosis codes you can use for impending, threatening. They're leaving your office. We know they're going to have a heart attack soon. That's your diagnosis code you can use. That was on their exam this weekend. So I need to write those scenarios down, and a possible pneumonia will be another one. Is it a good idea to take the Aapc course? If you have absolutely no medical history whatsoever in coding, have never worked in a doctor's office or a hospital as a receptionist or anything, maybe. It's going to teach you the basics, but what I recommend more than anything is I had it today. What did I do with it? There it is. I got it turned open. Is the Aapc's study guide for CPC. This little workbook, but it's 300 pages, has everything the course has in it. Everything in a compact little way. It's still way too wordy, but it's okay. I would definitely get this study guide. I like it more so than I do the course. And what I would do is, come on, all the business of medicine. Come on. There we go. All the business of medicine. This is the stuff with the definitions for like what is HIPAA, what is fraud and abuse, all the compliance rules, all those things that I want you to write in the front of your CPT book before the E&M. I mean, you got a whole list of all the definitions and everything right there in those 3 pages that they have all that listed. Those 3 pages, go write them in the front of your CPT book. This book is pretty cool. And then it goes through all the anatomy, and then it goes through coding, what the books are, what they're doing, and then you do have some exam questions in the back. It's just as well, I mean, if you're going to spend $3,000 on a course, and it doesn't even matter if you have an old year, it hasn't changed. Even the exam questions back here are the same. So any version of this that you can get for any year is just as good as any course. If you have a grant or have the money to spend without any financial hardship, go for it. But if it's going to be a financial hardship, just get the study guide used off eBay. Use YouTube videos. And yeah, practice the process of elimination and what I've got going on here. And then there's, I'm sure some of my people can direct you into some other YouTubers or other people that could help you out too. But you can definitely do the self-study route. You need to know what part of Medicare, Part A, B, C, or D, covers nursing home facilities. Nursing facilities are covered by Part A. Part B, you should know. Part C, you should know. And Part D, you should know. If you don't know them, or even if you do, you should write the definitions over there in the front of your CPT book so you could have it during your exam so you can go over those super quick. Yeah, good. Awesome. Let's see, I'm going to check up with chat. Here's some more vocabulary words you should know. Be sure and either write those down and then get them in the right spots. Thank you, Destiny, for hint, hint, TikTok. My boys are so fun. They really are. QS is definitely on the exam. Yep, for sure. Thank you for the follow, Danielle. Are the CPC exams different? I took one November 6th and failed by taking it again on December the 11th. There are different versions. If you took it in person, you might have noticed if you took version A, B, C, or D. A lot of people are getting A and C right now, but I do have a lot of B too, so I don't know. There are different versions. That's why I have this labeled right now. This is part exam A, and then I have B later on, then I have C, but if you take it online, you don't know which version you're getting. And I have a collection of information that was on online exams too. I have 0 experience coding in the medical field, so a study guide would be enough. Yeah, sure would. Don't remember which one I had. Did you do it? Awesome, thank you. That's okay. It doesn't matter, really. A lot of the exams, A, B, and C, do have some of the same information on them, but some of them are exclusive. Like one of them seems to be more urology than anything, and then one of them seems to be something else. So it's okay. If you've got more information than you need, then great, but at least I'm here to help you. And one lady just went through this weekend, and she was like, it was exactly what I shared from this Word document was her exam, and she walked out smiling. So that's super helpful. Yeah, I get the coding books bundle from Aapc. When I order my books, I get all of them from Aapc. I do it every year when tax return comes out, so I have the extra money to blow. I just go on and renew my membership, produce my CEUs because they're due in June, and then buy my books that way. Be sure you know that the venous valve is part of your musculoskeletal system. It is not a part of the heart because you think it would with the valves. Be sure you know what thrombophlebitis, whatever means. It's the inflammation of your veins is. Sepsis. There's 4 different ways to code sepsis: with organ failure, without organ failure, with a dysfunction, and with E. coli and stuff. So I have a 1-sheeter on how to code sepsis that I can share with anybody. If you message me, let me know you need it. But I've shared it in our messenger chat group too. So I have that posted. If you're in our messenger chat group, you just click on the little eye icon up here in the top, scroll down to photos and videos, and all the photos that I've shared and everybody else will all be here, including how to set up your camera in case you need to take the test online, all of our little cheat sheets, lots of cool cheat sheets for lots of party parts, but also cheat sheets for neoplasm are here. Ones for sepsis is going to be here too. There's just lots of information here that you can search through for the photos that are super helpful. Yeah, super helpful, including this one picture. Where is it? That got shared this week. One lady who took her exam this week, 3 of her exam questions were all from this one page. One page. Super helpful information in our chat group, and it's free for everybody. You don't have to pay for anything here. The only thing is tutoring with me. It's like $27 for an hour and a half or whatever, with one-on-one with me and my books. And then if you want page by page of what's in each one of my pages of the CPT book, then I have those printable for you on Etsy. But hopefully it won't be too bad. But sepsis is in here. There's so much information in here that can help you out, even how to prep your books and all kinds of stuff. That's the fish scales that they'll put on your skin. I was talking about allografts and autografts this week. So that's one of the exografts. Be sure you know what the abbreviation ARDS means, what an ABN is, where the phalanx bone is, how to code a multiple delivery, that you will need a 7th character that will add the number of fetuses there are to the ICD10 code. That's one of the questions there. You'll also need a 030 code for multiple gestation. It's an extra code. I have some examples here, like Mary was pregnant with twins. It's close to her due date. She noticed fetus 2 was in the breech position. So you record that code for maternal care due to the fetus being in breech presentation, and the fetus was fetus 2 so that's why it ends in 2 right there. So they like to give everybody a number, even when they're babies in their mama's tummy. Everybody gets a number. Just keep that in mind. If you need to code multiple things like HIV with a leg injury, what would you code first? So the leg injury would go first, and then HIV second, according to the guidelines. So keep that in mind. They have different guidelines for metastasized cancer. So if a patient has brain cancer that metastasized down to their lungs, but they're seeing their lung specialist for that lung cancer, then you would code their secondary cancer first, then their primary cancer first. But if they're being treated for chemotherapy or radiation, you know that you're going to code the Z51 code first, for the treatment of their cancer, and then you do their primary cancer first, then their secondary cancer, and so on. The HIPPICS codes that were on somebody's exam was the S1031 for the glucose monitoring rental. This surgery procedure, I love how it says in humans, that repairs the defect of the walls of the vagina when it's falling in on itself later on in life usually, or after multiple deliveries. We've got several codes from the 99 area. I haven't gone through and written examples on all of them yet, but I have the 99218. This is an example as a patient receives observation care for less than 8 hours and is discharged on the same date. What would you code? They were like, patient was assigned status at noon and then they were discharged at 5 p.m. on the same day. It says you may report something between the codes 99218 and 99220. The differences are going to be the level of difficulty. So if it's just an asthmatic patient who comes in who couldn't get their asthma under control and needed to be under a breathing treatment machine for a couple of hours, then that's fairly simple as far as observation goes. So they would definitely get the 18 code. You would go on up to 20 if it was an allergic reaction that gave them several systems were involved. Their breathing, their skin was erupting in pustules and craziness. They had agitated state, were disoriented along with it, which can happen. I've had anaphylactic shock once in my life, but I've had reactions and allergic reactions to several things all my life, including this weekend. I had one that it was pretty impressive, but I've got it all under control now. But I still have some residual effects. The red dots that are popped up everywhere on my hands are from the allergic reaction to some sort of cream that the doctor gave me for those 2 digits that are frozen right here that I can't move anymore from an injury from July. They gave me some sort of something that was supposed to help me move those joints, but of course I broke out and huge, massive reaction to that. Nothing that needed to go into the ER, but I have had to go there before. It's definitely a more difficult situation when you're having to deal with respiration and skin stuff and heart stuff. Hearts can go crazy during an allergic reaction, along with decreased breathing and all kinds of stuff, where you could get a 20. They can still be discharged. You just have to work really hard to get that under control within the same day. So that's the differences in those. I still have all these codes I need to go through. This right here is our critical care codes that I went through in person on our book. I showed you if we do have critical care, we love it. All we need to know is the minutes. Her minutes was 105, so you just go straight to that chart. Sorry. You go straight to that chart and pick the correct codes section for 105 minutes. So your other codes that were on the exam are 99234, which I don't have an example for yet, 99385, but I know these are the critical care, in case you missed any of that stuff. Got a whole bunch more. I still have to write some more information on these. The 99475. The CRNA for monitored MAC anesthesia. They had a patient who was a P3. You know P1 is for a healthy patient. Maybe they get in a car wreck and they come to the ER and need to have anesthesia. Otherwise, they're a healthy 20-year-old. We just need to manipulate their arm and put it back into place. They're a P1. P3 is where you would have a status of a patient who has like more comorbidities before they get anesthesia, like they're hypertensive, diabetic with COPD. That's a P3. P6 means they're brain dead and we're just harvesting organs, but we're putting them under anesthesia to ease some sort of pain, I guess. But they definitely used 3 modifiers on that anesthesia patient, which were QZ, QS for the MAC. QS is for MAC. QZ is for your CRNA doing the anesthesia, nurse practitioner. And then your P3 means your patient was fairly sick person already before they went under anesthesia. They also had the anesthesia or modifier AA on their exam. They had the 85-year-old patient who got the anesthesia code that I went over already for the 99100 code. Then here is a list of all the 200,000 codes, 2,000 codes, whatever you want to call these, musculoskeletal codes that they went through, their respiratory and cardiovascular codes that were on their exam. I need to write examples for each one. Then we've got their 4,000s is that nervous system, somewhere around there maybe, gastro. They had hernia repairs on there. They had some hip picks right here for their S, or is that the 5s? Those are 5s. Those are 5s, not hip picks yet. Those are 5,200 and then the 5,400 codes. I had a lot of these. A lot. I'm telling you, I got to update all of this. I want to match and see if my pink codes in my notes are the same codes that they have listed here. She gave me everything that was on her exam. I don't know how she concentrated and finished her exam on time, but she did a great job of sharing information and codes that come along with it. I mean, she went through the entire exam here. It looks like we've got our lab codes, we've got our medicine codes, we've got our hip picks codes, we have some diagnosis codes. The knee was divided into 3 compartments. The other thing that I noticed is that they have the shoulder divided into 3 compartments too for the CPC exam. Here's the 3 parts that are part of the 3 parts of the knee. You have the medial, the lateral, and the patella. The toxic effects of ingesting mushrooms were on her exam. It was accidental, not intentional. Initial encounter, that one, there's your code for that one, was on her exam. We've got exam B notes here, which have been added to 2. This one seemed to have a lot of urethra and urinary issues. There's lots of things that can happen to the ureters or the urethras for coding, so be sure you know the differences in those. There's 4 different type of blockages right there that could be dealt with. She also had to have, which seems to be very difficult to do, this part B, with all the urinary and the skin grafts. Pretty difficult exam. She did have split thickness grafts and full thickness grafts. Yeah. Is that helpful? So I separated them out by definition of what is each one of them. So autografts means you are the owner and driver of all those body parts being put on you. It's your own body. So think of it that way. Allografts have 2 legs in it for the L. So those body parts walked over to you. They're usually cadaver skin or something like that. And then animal products like pigs or maybe even the fish scales are exografts. Yeah, take pictures. Don't try to write all this into your book right away because I want you to stay organized. Be sure to put it where it needs to go. And then I separated out the grafts by each area. So the split thickness grafts are here by codes, by body parts, and then your full thickness grafts are by codes, by body parts. Be sure you know how to code CKD for your third stage hypertension questions. I have some examples here of those. Like, how would you code if the provider documents that they had exacerbated chronic heart failure, CHF, with hypertension? You're going to report your I-11.0 for hypertensive heart disease with heart failure and I-50.9 for heart failure unspecified. And I have some more with the CKD and some more with the CKD right here too. Writing these examples in your ICD-10 book with those codes is super helpful. You have it as reference during your exam, and then just refer back. So, I'll show you what I did on mine. If you go to N18 on any of in my books, I'll have all these little listings like example of a pregnancy that had CKD on page 889. So if I go to 889 in my book, because pregnancy obviously would have been diagnosed first, right? But I keep the color scheme the same, guys, and then I go to the original and my very first code that would be written in that example, which is my pre-existing kidney disease in an OB patient. Then I did her hypertension, I did her CKD, and then she's 29 weeks pregnant. That comes at the end. So according to the guidelines, you diagnose this patient in this way, in this order. So if you go to any one of those diagnoses, it'll refer you back to the main page with the very first diagnosis on it, so I can see the whole original setup in the way that it was. I did all my book like that to reference all my top 10 guidelines or my top 10 diagnoses that are usually gone over in the book. Now, there's only a few diagnosis codes usually picked for your CPC exam. It's not like the CPT where it's 100 questions. There will be 10 questions for ICD-10, but I don't mean go through there and do a million things, but be sure and do certain areas like burns, OB, CKD, anything that I reference in this examples that have been on people's exams recently in the last 60 days. Be sure and write some examples in your ICD-10 to help you reference during your exam to show you how to code it in case you get blindsided by something or just want to check and verify for your peace of mind during your exam. Be sure you know how to do scenarios with these modifiers, 53, 22, 52, and 59. I wrote those particular definitions down, and I did some examples here if you want to screenshot any of this. If I can spell anything. Did I spell that right? I don't think so. Separate. It's not picking it out. I don't know. I also separated out the modifiers by pricing modifiers, payment modifiers, body part modifiers, just to make it a little easier to think of them rationally that way. Here's some more urine stuff that was on this exam B. They had incomplete uterine prolapses. They do have first degree, second degree, and third degree prolapses. Know your definitions on those. And then I did some clinical scenarios, so you can go to those diagnosis codes and write these scenarios down near them for help. I also did another one right here with the CPT code that went along with it. Be sure you know which hormones regulate sugar. It's glucagon, but it's also insulin too, so be sure you know those and what they do for the body. We've got neurotransmitters. What do they do for the body? What do they send signals, right? So be sure and know that. We've got the definition of OIG, which should go in the very front of your CPT book before the E&M codes. This is an example question that's usually on the exam, and D was the answer. So be sure you know how urine is transported, what is used, ureters. The 80053. So a lot of these labs, when you're in that section and taking that part of the exam, they're going to give you a bunch of things they want you to have coded. And they usually don't list them out as a panel like they are listed in the book. So you have to go through and make sure that you know which ones of these would make up a panel that's listed in the front of the book, right? So one of their examples that they like to pick on, let me get up here in the front of this book, is the comprehensive and the basic panel. A lot of doctors like to order a comprehensive and a basic. What I've done is written out how many tests are in each so that I know however many tests are in it. But if your exam question says the doctor ordered a basic and a comprehensive, would you order those two tests? You wouldn't, because the basic has everything in it that the comprehensive has in it, except for one thing, which is the calcium ionized test. The calcium here is just a calcium total, so you would order this test with that one code, because you don't need to order this code because this is all repetitive stuff, because this is already over here. So you would just pick the answer with that number and move on with your day. So having the numbers, some of them list out like it has a comprehensive in it, so you know that has 14 in it, and then you got to add the other 3 that were with it. So some of the things, I don't know if it's super helpful to have the numbers there, but I do on mine. The other thing in this lab, which is rough, is sometimes they're only asking for a positive or a negative result, which is like an essay, and then the other ones they're asking for a therapeutic level. So they may have these labs or the words or the definitions for certain things in several places, because in one section, if you're not paying attention to your header, you are looking at just a positive or a negative result, and it doesn't tell you in the CPT description. Another place in the book will have the same words listed, but you're doing a therapeutic level, so how much of it is in there? So that's where a lot of people get things mixed up in. Some of the tests are done by enzymes. Some of them are done by a nucleic acid test. Same test, but it's listed under enzymes or it's listed under nuclear tests. So you need to make sure you're under the right header, where a lot of people get things mixed up in that section. It's a very difficult section, even if you know what you're doing. So I like people to get other sections built up better, like cardiovascular, radiology, other areas done up better, so that you can, if you do poorly in lab and path, you've got some room, some buffer to go on and maybe not pass that section, but go on and pass in all the other sections with an 80% that'll make up the difference between lab and path, because lab and path is super difficult. Even when you know where everything is and know what you're doing, it's super hard to code. It's rough. Okay. Everybody okay in chat? Everything's all right? Hopefully. Okay. Let's continue going. I got some more new added information down here coming up soon. So, if I could see. So, we did the lab. HitPix holds temporary national codes. Yep, we know that. Be sure you know exactly what that means and that's what that book's for. Miscarriage question. There was some E&M stuff going on with it that was medically induced by oral ingestion. Be sure you know where you might code something like that. This is the shoulder being in three different spots. I mean, there's 3 different areas of the bone of the shoulder that they were going over. Be sure you know what the CLIA is about. It's a laboratory amendment. Every 2 years, every lab has to go through it. They have to pay fees and be examined because they're dealing with body parts, really, human blood, sputum, urine, fecal matter. They have to go through an evaluation, so be sure you know what that is. Come on, creamy thing. Work for me, please. Fraudulent question pertaining to Medicare. E4 modifier, that's about the eye. We had the etropin procedure where they keep the eye from running off in different locations. The 3 parts of the shoulder, the part of the eye that is transparent. Medical terms like the removal of the tear duct. Sometimes they'll ask you about things called the internal cervical OS opening, which is the opening to the uterus, then the external cervical opening, which is the opening to the vagina. They were big on that on exam B. They also had the colposcopy, which is to examine tissue from the cervical or vaginal wall. We used to also do LEEPs, L-E-E-P. Those are also procedures where you get tissue from the cervical wall to examine. Be sure you know what the prone position means, that you're lying face down. Sleep study, the 95860 was on there. The condition with the pigment of your skin makes it white and swirly looking. No one knows why it happens and suddenly does, usually around the late 20s to 30s. The nursing facility code. What does IVA mean? There's several definitions for that. I'm not sure what they were looking for, but it could be anything from intravenous anesthesia to influenza vaccine. Not sure on that one. There's a lot of different areas that one could be in. I didn't have any context on that one. The my ring, this is the surgical procedure to make an incision in the eardrum to drain the fluid out of. Modifiers, TC. This is the new information from another person that gave me all this information this weekend that I need to fix and add more stuff to. We've got a 98928. We also have 91132. Be sure to know what type 1 diabetes means, what a group home is, what Medicare coverage, something about 30 days, what helps you regulate waste, gallbladder, stores bilirubin, the pineal gland. We've got another HitPix code of 80225. We had these 2 lab codes. We have the QM modifier. This information from here point down was shared on September 28th, and I kept forgetting to add it down into the list of information. What was the transparent color or part of the eye, which is the aqueous. You know, I have that down on my notes in the eye section. What is OU? That's one of the eyes, right or left. We've got joints. They had a copo and cornea. Pancreas, islet, and its function. Which part of Medicare covers assisted living? The Warthin's tumor of the salivary gland. We had the infection of the lacrimal gland. We had the joint of the knee. They had ABN again. The respiratory disease. HIPAA abuse. This person had version A2 of the exam. Hers had a balloon catheter in stenotic valve for caliphate, aortic valve. They had stenosis. They had a fistula, shunt for dialysis, femoral stem, HIPAA services, fraud abuse, NCCI, National Coding, Correct Coding Initiative. Part A pays for nursing, skilled nurses, ABN. They had impending condition, the myocardial infarction that I went over and showed y'all in the ICD10 book. I'll get it listed over here. The diabetic polyneuropathy. They got those electrical outlets that, spring out throughout the body. Those electrical stuff is not fun. A tumor and its uncertain behavior, how to code that. Sepsis with acute respiratory failure, which is on my sepsis book, my little cheat sheet. I guess I say it book. It's just a cheat sheet. Hold on 1 second. Travis, stop. Get off the couch. You're not allowed to be there. Move.
He kicks me off with his foot.
Come on. Somebody move. Or I'm bringing my live in here to watch y'all. Come on. Somebody move. Or everybody has to go to bed. 1, 2. No, you're not. Put it back. Okay, you come here. Come in here and you can sit down with me. I don't appreciate how unhelpful y'all are. This makes me very sad. Whew. Good Lord. They're fighting on the couch, kicking each other. My goodness. Little school, and they go nuts. The kids, boys are like all testosterone, and they're sitting down in the classroom behind a desk all day long. They have no outlet to release all that testosterone, and they are just buck wild at the end of the day. Here we go. Sepsis. Screenshot this, please. Write these 4 scenarios down when it's organ failure, E. coli, staph infection, that kind of stuff. Super helpful. Oh, where are we at? Twins. She had 1 vaginal and 1 breech. Guys, you're going to code your breech baby first, even if they were born second. Anything, usually, whatever is going on with that patient that day, whatever thing was your most difficult thing to deal with, is always coded first. Same thing for integumentary. If you're removing cyst, biopsies, lesions, sewing up stuff, cutting off skin tags to doing just a punch biopsy, you're going to code the most difficult one first. Somebody had a question on their exam, speaking of integumentary, which one requires irrigation? Would that be simple, intermediate, or complex procedure in integumentary? Integumentary. I know I'm not saying that right. And it would actually be intermediate because that's a layered procedure, because you're usually removing dead tissue, infected tissue, cyst, the pimple popper lady. She's doing a layered procedure. It would not be complex because usually complex procedures, you are grafting stuff in there and you can't put healthy tissue in with diseased tissue. You need to clean all that out, do some layered sutures, give them some antibiotics, hope it heals. If it doesn't, you can do a graft later, but you've got to get that infection under control first. So super helpful information there, for sure. If she also had the poisonous wild mushrooms, she had the sesamoid, she had the urethra, she had the conjunctivitis. They had a knee joint compartments, the medial, lateral, and patella, which I already had, the Warthin's tumor. She had a spleen issue, a pancreatic islet, the venous valves. Remember, those are in your joints, help you move things. She had ARDS, meningitis, the phalanx, which are bones in your hand, the coprophory, again, and malignant neoplasm of the skin, maybe a melanoma. I'll get y'all some examples of those. The endoscope of the upper GI method, was it transoral? An excision of a lesion, diabetic codes, not listed first, CKD plus dialysis, and modifier 53. Some of the codes she had were S1031, which we knew. The Q4006 is new. And here are some more CPT codes that she listed down. You had our ARDS and meningitis too. Good info. I will get y'all more information on all these codes for sure. We had a procedure that required irrigation. There's that question, the simple, intermediate, and complex. We had JVD, which I had to go right in at the back of the CPT book because it's not listed. For jugular vein distension, I guarantee you that's on design. Aapc went through those abbreviations, noticed that one wasn't in the list in the back of the book, and used it. Here's your islet of the pancreas right here. It's a Laggerheads, or which part of the body system. Are they reproductive, nervous, or digestive? It's actually endocrine is the right answer for this one. So when you see islets of the Laggerheads, you are dealing with the endocrine. We have from Jess that took her test this weekend, a situation where a doctor working in his own private practice goes out of town for a month. He has another doctor who comes in to his office and sees his patients while he's gone. How would you claim or bill that scenario? So you still use the doctor who's gone, NPI, with the date of service, and the place of service is his office, but you use modifier Q6 to the E&M code to list that that is being done by a doctor who's filling in for the one NPI that you're using, National Provider Identification Number. It's for billing purposes, but for our question for CPC, be sure and pick the answer with Q6 because that is your modifier. Which procedure requires irrigation? Again, that was in there. And here's some more Jess Exam C, some of her stuff. She still had the same the ear procedure to remove excess infection and fluid behind the ear. She had trichomonas, which is an STD. She had outpatient surgical, modifier 22. Here are some CPT codes that she had. She also had this Corpius, whatever that last word is. I'll get you some scenarios on this one. The renal femoral artery angiograph was also performed. Right common femoral artery. She had those things that goes with those diagnoses. She had a patient underdosed for insulin and a pump malfunction. What goes on there? And someone with a fracture with HIV. You know you do the fracture first. HIV will be second. So that's all the information right now that I have on what is currently being given on the exams, A, B, and C. Super helpful if you did watch that and we've collected it and you add that to your memory banks, which is your books. I wish I had more information, but I am, one person. I need to go through here and add, like I did to the beginning, examples of everything, and I will get that done. It just takes time. Right. Now I am working on, I'm still on E&M. Oh my gosh. I still have not finished the 9-9 codes for 2022, but I am working away at finishing these scenarios, putting them down. I have down the codes and what exactly you need to highlight in each CPT code, and the pink codes, of course, are the ones that are on our exam, and then over here to the sides I have clinical examples of exactly how to code them, what not to code with them, advice on other things too, anything I can find for it, hints and tips about where things are and reasons why you would code them there for sure. Just lots of information. It's going to be cool when I get done with it. Super cool, but I'm getting further and further down. Further and further, for sure. Lots of coding tips. I'm down to the nursing care stuff, so around in that area. Now I've got to finish up the rest of them. I'll eventually get done with it, I swear, and then I can move on to anesthesia and get those done. I've got a lot of the prolonged services done here. Super helpful having all this written out and explaining exactly why you would code one way and not another. I think it's going to be super helpful, like the ICD10 was. We can do some practice process of elimination codes. I'm sure y'all are wanting to see some of that for sure. Process of elimination can be super helpful in the exam itself. It is a way to save your brain during your exam for sure. Oh, come on. It loves to focus on pictures instead of numbers for some reason. But if we were looking at this particular question, my process of elimination, the way you should take this exam and the way you should take all the practice exams, all of you running through these practice exam questions that you're purchasing from Aapc, stop looking at them from reading the question and then looking at the answers. You need to go straight to the answers and do what Connor and Jess are doing right here and pick 2 codes to keep if you can and 2 codes to get rid of. So we are only looking at these numerically, and so since we have 2 that are the same, we're going to eliminate those other 2 answers. We're going to go to 81 and 83 to see if we could combine them or if we couldn't. When you get to 19081, where are we at? We're in integumentary. Speaking of that, I've been talking about it all day long. 19081 is over here, and 83 is over here. Would you use 2 parent codes in the same thing? Same answer. Would we do a breast biopsy with placement of breast, localization. What's the difference in these things? This one has a device clip, first lesion. This one's with stereotypic, and this one's with ultrasound. Would you code these two in the same answer? Could that even be possible? No, it couldn't, right? We would not do two parents in the same one. So without even reading the question, which is quite lengthy, of garbage, we did this question without even looking at the question at all. We just went with the process of elimination, looked what didn't work, and we're left with the only answer it could be. I know it's scary, but this will save your soul and get you through that exam and have you not memorizing a million things and keeping it with you to the next question. You don't need to know that that's a 53-year-old woman and all of her history and all this stuff going on with her. You just need to get through this exam question without getting any propaganda thrown at you. I know. It's a lot. It was a lot. We were in our chat room today, and somebody, let me go right here. Shared a question, and she got it wrong 3 times. And I tell you why you get it wrong 3 times is because you read it from the beginning to the end. If you'd have just looked at these, figured out, okay, it's between the 20s and the 80s, go see what the 2 differences are, okay? Then go look for word search from the bottom word up. You would have never gotten to the top where it says ER, which got you confused because these 2 are ER visits, the 8.5 and the 8.4. If you had looked at it like I suggest, from the last word backwards till all you need is that his PCP admitted him. He was admitted. The only 2 CPTs, these 2 are 85 and 84 are for ER. These 2 are for initial inpatient whatever care. Then all you need to do is your MDM. Your MDM, and then pick out the difference. If you read these questions from beginning to end, they're going to confuse you. They put that ER word in there to make you think it was one of those 2 codes. But that's not what happened to the patient. He was admitted. He wasn't in the ER. He got admitted. They put a lot of propaganda in these questions to confuse you. And if you're going to read the question from beginning to end and then look at your answers, you're not going to pass the exam, is my experience. Number 1, you don't have time to read all the questions at all and analyze what's going on. They don't give you enough time, for sure. And you're not coding. Y'all keep attacking these questions like you're a coder, and you're not coding. The coding's been done for you. All you have to do is pick out the right answer. And they've put a minefield of stuff in the way to make you think that you're going to be coding the example in a different way by adding in trick words. If it's bilateral, they'll add in a bunch of examples to make you think that you're going to be using a bilateral code or not, or it's just ridiculous, all the stuff that they go through to put into those questions to purposely see if you can fail, for sure, is my only explanation for all that. Question that we in. So for example, this one, all of it's the same. The whole front code is the same. The modifier is the same. The only differences are these things, the 14 and the 53. And this is all the same with the same modifier. So all you have to do is go find out what the differences are between the 14 and 15. That'll help you eliminate just two of them, right? So 12.0.14. Boop, boop, boop. 12.14 is under simple repair, and then the 53 is under intermediate repair. So you just need to look for your key terms on intermediate, right? You're definitely not doing simple if you've got different types of different types of sutures. That means you're doing something layered. You got two different types. You put one type of suture in one area and one type in another. So you can get rid of A and C, so you know it's only going to be a difference between B and D. And sorry. So this one's definitely going to be between B and D, Jess. And then we're just going to be adding, these are done by how many body parts she's got going on, right? You know, they're simple and intermediate she has. So we've got our office visit, and then she has her codes for what types of her procedures. If they're simple, intermediate, complex, you divide them up that way. There's not ever going to be a reason to add that 1200 to one that you're only doing in those two locations. So you've definitely got your D going on with this one. She's got lacerations on her forehead, cheek, and chin. The total length is 6. Then she has of the right arm, they even divided it out for you in just 2 parts right there. That's super nice. Usually their questions are not that easy on the exam, but you only have 2 areas right there. So you only have 2 areas here. That's how I like to do them, is just separating them out by which location they're at. Super helpful on that, because those repairs, you add up the sum of the links. It doesn't matter as long as you're under the right location. She's got, and you make sure that your codes are done in this correct order. Even looking at this one, if you look at C, see how that 14 is before your 34? That would never be an answer anyway, because this is a deeper procedure than the 14. You would never code it that way. You always code the more difficult procedure first. So don't forget about that particular thing that happens with all these. You know, you got to make sure they're in the right order for your integumentary system. You got to have your big dog before your little dog, for sure, on all these. Even A is done that same way too. It's a 14 with a 34 behind it. That would never happen. So even just, I really probably didn't even need to look up the difference between the 14 and the 34, because actually these could not even be right to begin with, because the littler numbers are before the bigger numbers, and you can't have that in integumentary no matter what. It would at least get you down to half. You'd know halfway. You'd know you have 50-50 shot on this test question. But they're just divided up by the body parts, and then you add up the sums on these lacerations. And she only had, and there's only, on the complex repair, yeah, and then the intermediate, yeah. The intermediate, you've got 3 different locations. The simple repair, I believe you only have 2 locations, right? 2, 3. You got the 3 locations. So you got 3 locations, simple, intermediate. You just divide up how many are in each section, add up the sums. Gotta get the pointer going on so I can adjust. This one's that cool. ORIF's procedure. This one's in anesthesia. They're all P1, so you don't have to worry about the modifier. And then it's just a difference between the 30 and the 60, right? 30 and the 60. So what's 1830 and what's 1860? 018. Don't forget you've got a lot of open and closed procedures here, and I did these all wrong. I like to circle the open procedures in green and then the closed ones in orange. And there seems to be a lot in the knee and arm area in anesthesia, and I marked them all wrong in this book. So, you know, green is for the open and orange is for the closed. So there's quite a few of those that need to be marked a little differently in my notes. 1830 is right here, and then we've got 1860, and they're under the same heading. Yes, so one of them's open procedure, and then this one is just generic, huh? Or cast application removal. Since when do you need to do anesthesia for a cast application removal? Don't know. Maybe if they're super young. But this one's 32, and they did a closed fracture. And they did get their monitored anesthesia for their distal radius, right? Crazy patient, I guess. I know, right? When did you ever need to put them under to remove a cast? That just seems so unlikely. So I wouldn't use the 60. Definitely use that 30. So get rid of those 2. And since you need monitored anesthesia, and we have a healthy patient who just has a fractured arm, what would you use? Yep. Don't forget about your MAC when they say monitored. Anytime you see MA, you are definitely going to use that modifier QS for sure. Every time. Super helpful for the coding exam. All right. kids. Oh my gosh, my kids are distracting me so much. I had quite a few of gunshot wounds, GSWs, on my CPC exam. Nobody recently has said anything about a gunshot wound being on their exam. It's kind of interesting. I'm wondering if anybody remembers anything like that. But I had several on mine. They ended up getting injury codes with those codes in the back for all kinds of situations. Our external causes. I seem to have that a lot. And then I had a chainsaw injury and a bar fight injury. I don't know if I was just the lucky one, but I ended up with quite a few of those. This is another example of a gunshot wound. Right here, they use this exploring of a wound for a trauma injury. Let's see if I can find another example here we can go through real quick. How about this one? Looks cool. Gonna need my ICD10 for this one. We did have some poisonous mushrooms recently on our exam. So this one is also something kind of related. They ended up having an issue with a patient who had bradycardia, slow heartbeat, due to Demerol that was injected and prescribed appropriately. How would you code it? Would you do the T code first or the R code? Because it was prescribed appropriately, would you code their bradycardia first and then the medicine? That's what I'm thinking too, and I am looking at an answer sheet that is telling me it is C. So now I'm like, what? How can that be right? Because it was proper use. We're forgetting our guideline, guys. So our guideline for a drug toxicity as an adverse reaction when it is prescribed correctly, the nature of the adverse effect goes first, and then the medication goes second. Oh my gosh, forgotten about that. So it is telling us our answer is C. So don't forget that when a medication is prescribed correctly, that you give the nature of the issue, which is the bradycardia, it's going to go first, then your medication second. It's totally different than some of your other guidelines for poisoning and other things. Whew. Definitely a weird one there. They're always really good at tricking you and picking out things that are difficult to remember and are tricky for sure. So remember, when it's correctly prescribed, you got to do your diagnosis first. That'll help you. So I would go to bradycardia. I would go to your T4s and write these scenarios down next to those codes, because It's going to help you during your exam have something to reference. What's going on?
Don't be purposely trying to make noise.
No, I'm not.
Yes, you are, baby. I can't function like this when y'all are throwing stuff around this house. What do you have in your mouth?
I feel so guilty. They just added the new boss baby to Hulu, and I made you.
Travis, you're just trying to change the subject. Sorry, my kids are driving me nuts this afternoon. And they're tearing up the whole house. And I don't have anybody in there that can watch them, so it's driving me crazy. And they know I do this every Monday night. I'm just not being helpful today. I'm just trying to find another one. We've done that one. We've done that one. I know we've done that one. What's this one? 10. Yes. I love this one. These moths are fun to do. I like them. Most people are scared of them, but I like them. So moths are, and we can look at this and know right away that without looking at the question, we're going to get rid of that one because it's not like the other ones. Then every answer that's left definitely has 13 first, so we don't have to worry about that. The difference is the two second ones, but since this one's different, we can get rid of it because it's probably going to be this one or that one. But would you ever code that code twice, right? One back to back, or would you do times two? That just looks really weird. Yep. So without even looking at your Moss question, you can pick the right answer right away. Yep. Yep. Love this one. You don't even need to look at the question. You don't need to stress about anything. We just did process of elimination. We knew it was going to be something that's super close. Usually there's just one difference. And that's how you should attack all these questions. Do these first. The ones you can't do, like this, either skip them, or if you're like me, I have to go do one question at a time. I can't skip through, but a lot of people suggest that if you run through the test and do them all super, super fast, the ones that you can, and then run the second time and go through the exam to fix the ones that you didn't do super fast, that's been helpful for them. Whatever process works for you, just try to do this process of elimination with your practice exam questions for sure. So this one, we definitely have the two in the middle that start with the first code, right? And these do come from Aapc, so we know we can get rid of these two. We're going to focus on these. This is the same. This is even the same. My goodness, this is the same, huh? So what's the difference? It's this one. So if we had burns, we're going to code the difficult one first. Then they're going to get smaller. So third degree, whatever, then second degree, and then first degree. Y and X we know are our external causes, like what they were doing, where they were at. So that's not going to be helpful. So the very last baby burn is what's being an issue between these two descriptions. So I would look up here for the least burn. So We're not going to do that because that's 3rd degree. 2nd degree is to her face. So it's probably the one that's the 10% of her body surface. Anyway, we just need to go look up T31, 11, and 10 to figure out which ones are the right ones. Where are we at? T3110. T3110. I'm slow at finding codes. So she's got 9% here, and then the 11 is 10 to 19% of the body. So the question was stated that they had 10%, so you'd pick the 11 code, and that's the only one you needed to look up for that particular whole question was B, because the 10 is for 9% or less. So 11's your one code. Not bad at all. If you just break them down logically by the process of elimination, Aapc, I promise, has this scenario where they give away at least one answer that's super easy to pick out that's wrong, like with this one, because the 60 was totally different from all the other codes. This one right here, these all started out the same codes, and the only difference was right there. So break them down like that. Don't be reading the entire question. Do not look up every code. You do not have time. You just need to get it eliminated down to just what the narrowest differences are. It doesn't matter who the patient is, what's been going on. All that matters is this one difference right here. And look how they're trying to make you think it's 10, because they put it in 3 of the other answers. They really don't want you to pick 11. So don't be fooled. Keep with what's inside the code descriptors for your word search and do your process of elimination that way. For sure. Super helpful. If you need a copy of my notes, they're on Etsy, of course, but main thing is joining our little social group we have on Messenger. Come find me on Messenger at just simple Jen Brewer. Get that back up. It's the same profile pic as the one on TikTok. And message me there if you want to join our group, and then you can join here. You can also just message me privately and we can chat, and I can share photos and helpful information, and you can share me your previous scores if you've taken this exam before there, and I can give you hints privately there, which if you don't want to be part of a big group, that's great, that's fine. I can give you hints that will help you throughout your exam there. I'm happy to tutor, and on my webpage I actually have screenshots of each one of these pages, so that it'll show you how to mark your pages and mark your CPT books, and what to do with your guidelines and things. That's super helpful. It's all free there too. And what else do we got going on? I'll put the repeat lives on YouTube. I added 3 more lives to it today, and you can watch me rattle on for 2 hours on different days of the week. My next live will be Wednesday night at 6:30 Arizona time zone. We don't follow any forwards or backwards. We have our own time zone, sort of. So Usually I'm about 2 hours different earlier than most of the country on the East Coast. So anyway, that's will be my next one. And then Messenger, if you want to be part of our chat group, we work in it daily. My website has screenshots of how to prep your book, what to put in it, and it also has an area where you can schedule individual tutoring with me if you feel like it. But I am more than happy to show you how to do all this and the process of elimination for free. Absolutely happy to help any way I can. Can't think of anything else. Does anybody have any questions? Can you show me the sesamoid gland? Yes. Yep, sesamoid bone. It is when you usually get a walking fracture in your bone of your foot. You usually get a fracture there. It's the big toe bone in your foot. It's the big toe bone. These are just muscles and tendons, but that's where your bone would be. Travis, stop, honey. Get off the furniture that way. We don't sit on the furniture like that. My kids are stressing me out today. Sorry, guys. Sesamoid bone. And I will definitely save this live if I can. TikTok has been really cray-cray lately and has not been saving my lives. I'll show y'all. I will go here and go to Creator Tools and go to Live Center. And it seems to be when I schedule like I can create a calendar on TikTok and have y'all register for the TikTok. And when I do that, it seems to do technical error, cannot record. And then that one it recorded. And then this one, technical error, technical area. I mean, like hours gone. Where did they go? So anyway, it's been being a pain lately. And if y'all submit anything for... Where is that? The TikTok balance for the Creator Fund. That goes right here. And I have, of course, not touched it. And when we get enough, we will definitely donate that money to somebody who needs a copy of my notes. And we'll send them some free notes. So that's where all that will go. But all the TikToks are here. I know I need to make some more TikToks, but super slow at all that. Super slow. But I hope this has been helpful today. I will get our exam notes that people have been sharing about what's on the exam into a better, easier format for sure. Here's our sesamoid bone, the actual real definition if you want to take a screenshot. And I will continue to update this. This seems to be super helpful for everybody. Maybe I can even get it in a format where people can download it or something, but we'll do my best for sure. And hopefully, thank you for the good night wishes. I will see y'all later. I will be in chat if y'all need me, and we can go over more questions. Let me know what y'all want to see on Wednesday's live. And I will definitely get that prepped and ready for you. No worries, Bella. I hope to see you later. Thanks, Shane. I'll see you later. Love. Lovey. Meemaw. She just joined. All right. Jess, I cannot wait to get your test results. Driving me nuts. I cannot wait. I know she passed this time. It's going to be amazing. We're going to see her shake, shake, shake. For sure. All right, guys. I'll see y'all Wednesday if I don't see you in our chat group. Good night.